Stroke rehab is an area where we as OT professionals have some of the most abundant research to draw on. But this can also make it difficult to synthesize all this information into the right action steps for your clients. To help you quickly scan the available assessments and evidence-supported treatments, we have been working on clinical decision support menus for occupational therapy professionals. And as you'll hear in this week's podcast, we have created a clinical decision support page to help support you in chronic stroke rehab. We plan to keep this page up to date and hope that you will scan through this page whenever you need ideas. But honestly, having updated information at your fingertips is going to be the new norm in our AI age. The real skill comes in your decision making, in strong therapeutic encounters, and problem solving with your clients. That's why I wanted to spend today's episode hearing real time how one of the OT leaders in stroke rehab, Christopher Gaskins, PhD, OTRL, CSRS, makes decisions in his practice. Chris has worked at Walter Reed, served as a consultant for the U.S. military, and now is going all in on his outpatient mobile practice neuro suite. And I just can't wait for you to hear this webinar that was recorded live on April 22nd, 2025. Welcome to the OT Potential Podcast. Before we begin, I wanted to let you know that this podcast may qualify as continuing education for you. You are probably listening to this podcast on a free podcast platform, but to gain CEU credit, you will need to be a member of the OT Potential Club, our OT continuing education platform. After listening, you can log into the club to take a 5-question quiz, and we will generate a certificate for your time today. Okay, here we go.
Hello, everyone, and welcome all around the world to our guests joining us for the OT Potential Podcast. I am Alan Linick. I'll be hosting moderating our discussion today on chronic stroke rehab. We are joined today by some very special guests, the first of which is Christopher. Christopher, welcome aboard. Christopher is a neuroscientist, occupational therapist, educator, consultant, technology nerd, and just an overall nice guy wrapped into one. Guess who wrote it? Christopher, how you doing?
I'm great. Yeah, that's definitely something I wrote about myself.
That's a great bio line.
It's really good. I loved. I was smiling as I read it. Christopher Gaskins is here to talk about chronic stroke rehab with us. He is also recovering from a cold, I've heard. So, you know, give
Bear
him
with me.
just know that like
here.
as good as he's doing today, this is like 80%. Do you know what I mean?
Yeah.
We also have Sarah Lyon here. Sarah is an OTRL and the CEO of OT Potential and is on a mission to bridge the gap between research and real occupational therapy practice. Sarah, how are you?
Oh, super happy to be here. We've been working on these chronic stroke resources for a while now, so it's really fun to be here to kind of talk through them and what it can look like in day-to-day practice.
Yeah, I'm excited to dive right into it. For the record, Sarah is not recovering from anything. So this is Sarah at 100.
This is what you get.
Yeah.
100%.
This is the peak. So as we kind of start delving into this topic, Chris, can you tell us how your approach to chronic stroke has evolved over the years and what you're excited about now at NeuroSuite, which is, I heard, about to become your full-time endeavor, your own
Yes,
private
it
practice.
is. I can't wait. A long time coming. So, how chronic stroke rehab has evolved for me over the years. I would say it's become more of a focus on transferring the patient's behavior in their daily routine so that it can be automatic and a part of their everyday life. So, I always tell my patients that the most important therapy happens when I leave the room. I didn't have that focus when I first started as an OT. You know, it was very focus on what I can do in the clinic, and I didn't focus as much as I could on generalization. So making sure that the skills that they learn in clinic actually carry over, not just home. So maybe not just doing it at home once or twice a week, but how can we make it actually become a lifestyle? So with my company, NeuroSuite, we emphasize that from day one. We have what's called a full circle philosophy. So, you imagine that the circle or like your well being is only halfway full when you're simply participating in therapy. But your circle, like of well being of life, is completely full when you're, doing, when your therapy becomes like your daily routine, when it becomes, automatic, you have like your blocked out time for it. So we just really try to emphasize that from day one. And that's probably the biggest change in how I approach chronic stroke rehab, because real change comes from sustained behavior change.
Yeah, does the language you use when you're talking to your patients, I mean, I assume, the way you talk to them has to change in order to like try to facilitate them implementing practices outside of the room with you in it, right?
Yeah, totally. Yeah, yeah, definitely empower them, but also almost just as importantly, I really try to connect with that caregiver and kind of represent all of us as a cohesive team. I was even speaking to a caregiver just last week, and she was saying how her husband does everything when the therapist is in the room, but when the therapist is not in the room and she's trying to get him to do activities, he won't do it. So again, I want to really facilitate a relationship between the patient, the caregiver, as well as the therapist, so that when it's just the caregiver and the patient, that caregiver can be a supportive asset to really help that patient. So immediately, I'm framing everything like as a team, and then also I'm framing the patient to. I let them know that they're in control all the time, even
Mm.
when I push my patients a lot. So even when I'm pushing them right to that moment where they feel like they can't do anymore, and they might start saying, "Oh, I don't want to do this. I don't want to do this." I just say, "Hey, you're in control. Like if you need a break, like you tell me, and we stop when you say so." So giving them that power, I think, helps a lot and helping them, really adopt their new lifestyle.
That's great. Sarah, I know you collaborated to create a clinical decision support for chronic stroke. Can you give us all just a quick background on that we can use as a reference point or a jumping off point?
Yeah, I'm just so happy to be here having this discussion, this clinical decision support. I want to say it's like a dream come true. I always practiced as a generalist, and I would pop around and see all kinds of different patients. And every now and then I would get like someone with chronic stroke, and I would be like, what does an expert in chronic stroke, what does their treatment look like? And how can I access that as a generalist? So working on this page where we got to collaborate with Chris, and who does this, has his PhD in it, does it, gets to practice with it and really flesh out like what does it look like to draw from the latest research and kind of create these I always call them menus of options. Like here's assessments, here's a goal bank, here's interventions that you can choose from. We have the link to the clinical decision support in the club, so you can be looking at it real time. And for people listening on the podcast, if you're not a podcast member, we also have a public facing version that has less information, but kind of gives you a good sense of what's in the different categories. So yeah, that's how it came to be. And my goal for it moving forward then is that we just continue to update it over time on a regular basis, either with Chris or some other expert in the field that we can. There's so many treatments that come and go in stroke rehab, and this like evergreen place gives me a place to like add new findings, add new research in between my podcast episodes. And I want to give a huge shout out to our capstone student, Ella Vanderpool, who spent a ton of time on this. She did such an excellent job. We could not have done this without her. Also want to thank Dr. Rachel Prophet, who got on the phone and talked about it. And yeah, we met with Chris on a weekly basis for a while, getting these pages up and going.
I'm curious about something because I just did a listen through of the last episode that Christopher was on with OT Potential, and it kind of ties into something I was thinking about that. So it kind of ties into something you were just saying, Sarah, about all this this plethora of research that's available, and it feels like there's so much more that we can do now to treat that sort of like acute stage of stroke, that now the doors are like really wide open for like, okay, well, now we have a lot more chronic stroke patients that need help and are looking for treatments than we've ever had in any other point in history, right? Because we just there wasn't such a big pool of people who made it to that point. So I'm just curious, especially for Chris and for Sarah as well, looking to like compile this clinical decision support and looking at like all the assessments that are available and all the treatment options that are available. How has this field like changed? Can you feel that in real time of like, oh, there's more, we're learning more every day, like there's these options are new, these options are new. Like how has chronic stroke rehab changed as medicine has changed, and how I'll stop there. I'm going to ramble and ask 50 questions in one question. Well, I'll leave it at that for now. Is just can you feel that change in real time, and what can you tell us about the difference between what it looks like now versus what it may have looked like 10, 20 years ago?
I can give a
Yeah.
quick answer to that where I'm just
Yep.
like, in all of our diagnoses, we are just on this like exponential growth of research. And to your point, Alan, there's so much need out there as we look at these chronic conditions. And those two things together are really what puts the pressure on knowledge translation. Like it has always taken so long to get new knowledge into like point of service practice. And that's why we have to be thinking about new ways to do that and new ways of practicing, where we have to think of like, how do you make it easier to scan the evidence that's out there and choose what's right for the patient in front of you? And this is part of our endeavor to do that. What do you think, Chris?
Yeah. So I'm definitely excited with like the increase in options for rehab. Like obviously like the increased like availability of different products, technologies. But within that same vein, I think it can be overwhelming for the caregiver and the patient because they're faced with
Mhm.
so many options. And then I think, with all these different options, it's important as clinicians to, ask, okay, like what principle of neuroplasticity is this product focusing on? So, for example, Flint Rehab, they do an excellent job. They really niche down. And to me, they really focus on, the principle of neuroplasticity called, repetition, or repetition matters. Like just emphasizing maximal repetitions because we know that that helps with neuroplasticity and motor relearning. But I think it's just important to really ask, how is this device or this product tapping into a specific part of neuroplasticity that we want to facilitate, or a specific principle? And then two, is it appropriate for the patient at this current time? And then also, I think it's best to keep things simple. I'm a tech, like I said in the intro, I'm a tech guy. I'm a tech geek, nerd, whatever you want to call it. But simplicity is the best. And sometimes it might not take the new shiny object off of the rack. One of the most amazing therapy sessions I saw. Shout out to this PT named Jason Knox in Canada. He'll be glad to know I'm shouting him out. But I mean, he came to do an in service at my old job, and he was training in the NDT. And I mean, he put my patient through a challenging like bout of exercises and movements with a broom. I mean, a simple broom. And honestly, that was probably more effective session that I've done with that patient like in, a couple months. So, I just keep that in mind, when thinking about the best products for patients. And I am encouraged by the increase of availability of products, but I'm always, thinking of what's simple. And then again, you'll hear me mention this throughout the night, but again, I'm focusing on how can we have change and sustained behavior. So any device that is allowing the patient to, if we can do remote, patient monitoring in the home or remote therapeutic monitoring, like I'm all for that because that's promoting accountability in the home. So that's always a plus for me.
Yeah, man, that broom story is really interesting, especially because it's a reminder that, yeah, at the end of the day, I feel like what a lot of patients are looking for is to regain the ability
Yep.
to use the simple things that they, that we would consider simple, but the things like opening doors, tying shoes, using a broom, washing dishes, like these are goals,
Exactly.
and going like so out there and so high tech can like eclipse the actual need sometimes. But so, okay, so I guess this all leads me into my next question, which is that given that we have this like robust list of assessments to choose from, how does one go about making the decisions for finding the right assessment for the individual patient?
Yeah.
Yeah, and I want to add, like in creating this list, when we dove into the research, there were like 40 options that we found. And we went, Ella went ahead and categorized them into these like 7 areas. So then there's like about 7 per, or 5 to 7 per category, but we have them in functional capacity and activities of daily living, motor function, mobility, upper extremity, mood and cognition, visual perception, and spasticity. And I look at these different assessments and I'm like, some of them are super recognizable. I would probably like tend towards those, like the COPM. But then there's other interesting ones that I would maybe initially skip by if I was seeing someone right in that moment, but would be interesting to dig into deeper if that like category was a need area. But I'm curious from you, Chris, like when you see this list, do you have go-tos that you tend towards? And just how do you choose in that assessment phase when there's so many options to choose from?
Yeah, it's actually challenging, especially for a neuro rehab company that has like a mobile therapy model. So treating patients that are outpatient clients but traveling to treat them in their home. You only have like a limited space of what you can put in your car, as far
Mhm.
as like assessments. So you have to consider that. So for me, not necessarily at the point of the evaluation, but that initial consultation or conversation I'm having with the patient and caregiver, because it's a team, I'm really trying to pry and understand at least what are reported deficits. Are you noticing any visual issues, any inattention issues? How's the hand moving, the arm? Anything I can kind of pick up on, and it gives me a general idea so that I can prepare at least what I think I might need. But the standards that I almost always use for a stroke survivor, especially if they have hemiparesis, is definitely a spasticity assessment, whether that be the modified Ashworth or the modified Tirdu. That's how you pronounce it. And then also just in my mind, trying to understand where they fall along that Brunstrom stages of motor recovery. Always just have that. And then obviously like your basic goniometric measurements and your either manual muscle testing or pinch grip or dynamometer. But if I have any kind of knowledge as far as how much digit extension they have, that might give me some insight into, okay, maybe they do have some dexterity. Maybe we can test for the box and blocks. If I know they had a mild stroke and perhaps they're like a lot younger, and there's reports they can grab things but they can't hold it. Maybe 9-hole peg test. If there's any hint that it might be inattention, it could be various things that I might look at to be able to look at attention or neglect. So all that to say, my go-to is really the box and blocks or the box and block assessment or test, the BBT. The Fugelmeyer is a gold standard. I'll probably use that more than anything else. Always a spasticity measurement, and then like your traditional goniometric measurements, or strength testing. And then that's the core, and then we build extra stuff around that. But you got to be mindful. You have limited amount of time, so I mean, you can't run the whole slew of assessments. You can't do it. So find what's the most meaningful. But that's
I
my approach. Yep.
I have like about a bajillion more questions about
Yeah.
I do too.
what the different assessments are, and why spasticity in particular seems to be like at the top of your list. What are your processes for streamlining goal setting?
Yeah, and in that, in our clinical decision support, we kind of went back and forth on like how to help people start those goals. And what we ended up doing was breaking down examples of goals according to those same categories that I just said the assessments were in, the ADL, spasticity, yeah, those 6 categories that I mentioned. And then from there, we divided according to therapeutic goals and assessment-based goals. So like in ADLs, that looks like there's examples of therapeutic goals for you around like upper body dressing, combing hair, dishwashing. And then an assessment goal is something like the patient will demonstrate a 1.85 or 1.85 minimally detectable change threshold or greater improvement in the Barthel index as an indicator of improved ADL performance. So kind of those two broad examples of goals within the different categories and giving people a broad bank to draw from. And when I practice, I always had like goal banks on a Google Doc where I would like just have a starting point for goals in. And I'm just curious, Chris, like what that logistically looks like for you. Like I think of you as being so good at like processes, and even from the goal bank that you developed, like seeing your strength, like you wrote beautiful goals. Those are way better than any goals I wrote. Yeah. Yeah. What does like that logistically look like for you?
Yeah, I should have a goal bank, but I don't. But when I take NeuroSuite full time, that'll be one of the first things I do. But quite honestly, I mean, it's a simple logistical process. I always ask the patient, when I'm doing my evaluation, I'll kind of prep them. I say, okay, now we're getting like to the most important part of the evaluation. I want you to tell me your hobbies. And they'll kind of pause. And they're kind of like, what? Like, what do you mean? Like, oh, what I used to do? Oh, yeah, what you used to do, what you would love to do again. So I like to hear those hobbies. Then I also directly ask them, again, and the caregiver, what are the most important goals? I explain what OT is, or how the OT that we provide in our setting, like what that looks like. And then I get an opportunity to express their goals. And I mean, it might be handwriting, going to the restroom. If it's something that's general as, move my arm again, I try to pin them down and say, well, move your arm to do what? And then honestly, from that, I mean, from what they say they want to do, and then from the hobbies, I really create the goals based upon that general idea, what they reported. And then I will usually have at least one or two assessment based goals. So patient will demonstrate like an improvement in their upper extremity Fugl-Meyer score by, X amount of points, to demonstrate improvement in overall upper limb function or something to that nature. Just to make sure that we have like this, standardized measure that we're tracking changes. But yeah, that's really the algorithm. That's what we do.
And I assume that, and please correct me if I'm wrong, I assume that then treatment options are sort of a direct, maybe maybe not a one for one, but for surely there's a correlation between what those stated goals are and what kind of treatments then we're going to be aiming at whatever the specific patient, right?
Yes.
So if there's a patient who's like, I would really love to be able to hold a paintbrush and like paint again. That was my hobby. I want that back. But even within something as specific as that, I imagine that there's like, for our listener only audience, I just threw my hands up into the air to indicate that I'm just, I guess, throwing spaghetti at a wall, because there's so many options for treatments out there, right? So even when you dial down into what our specific goals are, how do you comb through all of these treatment options and choose the right one for the patient and for the goal?
Yeah, it's very multifaceted and it's very, very dynamic. But I would say the biggest thing is for the session, like we build a foundation. So we recognize the goal, like the overarching, like, goal, which might be to paint, like using a paintbrush. But the beginning of session does not start with that paintbrush. It might start with a preparatory method. It could start with, functional electrical stimulation, maybe to like the anterior deltoid, prepare them for shoulder flexion. It might be, possible gentle stretching, weight bearing. Then we might progress to, guided assisted movement where they don't have a paintbrush yet, but they're simulating the movement. And then after that, we kind of break the task down. We might do an activity where they're simulating like gripping of the paintbrush. And then usually by the end of the session, we're putting everything together. So, I mean, it differs from session to session, but at least for me, my strategy is always kind of like, if you watch The Karate Kid, the people that have been around for a little while, like Mr. Miyagi, Mr. Miyagi's training the Karate Kid, and it's not really clear why the Karate Kid is doing these different methods, but by the end of the training, you're bringing everything together. So because of that, I mean, I take that approach, but again, I mean, what I might pick for intervention is fairly dynamic. I mean, I will say that I'm a big believer in the research that supports functional electrical stimulation. So I'm always utilizing that. Obviously, task specific training, almost always utilizing that, and then tapping into the motor learning theory, progressing from block practice, so doing a task, multiple repetitions, the same thing over and over and over, just to acquire the skill. And then by the end of the session, we're doing more what we call variable practice so that they can learn to do this skill, painting a brush, or using a paintbrush, like they can learn to do that like in different contexts. So we kind of, pull upon different theories, but yeah, it's really dynamic. I mean, it really depends on the patient, but it's always a foundation. Like we're layering up into like the big ADL or IADL at the end of the session.
Something that's so great about stroke rehab too is there's so much evidence to draw and research to draw on to inform that decision making. This was the first clinical decision support page where we were able to like color code according to the strength of
Hmm.
evidence, just because there have been like those systematic reviews done that really let us know like what has strong evidence, what has moderate evidence. I just want to say for our podcast listeners who maybe aren't looking at it real time, like in ADL and functional mobility outcomes, there's the green level, the highest support is mirror therapy with task-oriented training, followed by like moderate with aquatic and recreational interventions. ADL outcomes, self-management interventions has that strongest level of support, that green level of support. That's definitely something that I'm hearing like laced through what Chris is talking about, and something we talked about just again and again on the podcast. I was interested in the category that had the most green level evidence was actually that caregiver participation, which again, I'm just hearing threaded through everything that Chris is saying. And something I just find it valuable to sometimes go and look at those studies and kind of see what the protocol that they were using. And you can just kind of learn from that with your patients. Yeah, I'm curious, Chris, thinking of those like those strongest level interventions, mirror therapy, self-management. What do you draw from there? Or like, how do you interact with those studies?
Definitely a fan of mirror therapy, but I think there's evidence to support this, but I think there's a certain level of cognition and awareness that the patient to me needs to have to fully take full advantage of mirror therapy. And then also, I think the environment has to be conducive so that the patient can really focus on the mirror therapy. So, it needs to be quiet, reduce distractions, maybe even calming music to help them center. But I think it's important to shape the environment around mirror therapy for it to be effective. Definitely am a fan of it because evidence supports it. And again, functional electrical stimulation, also TENS, seeing good evidence for spasticity management. And then again, task specific training. It's just really, really, really beneficial. So those are kind of like my go-tos. It's kind of where I live in that
I,
space. Yeah.
I want to ask a quick question because I'm trying to be mindful of time. I'm seeing some questions already coming in on the
Yeah.
chat, and I'm excited to get to them later. So I want to make sure I save time for that. But especially because a lot of your previous chat on the OT Potential podcast was focused around augmented reality and virtual reality, specifically as it relates to chronic stroke treatment. I'm curious about how you feel like that plays into, or where that would fit in among these other things on the list that we just went over.
Yeah, think about utilizing, VR or even AR, as a complement or something similar, tapping into like the same neural systems that mirror therapy does. So again, creating that virtual environment that can block out distractions and maybe allow that patient to be able to see a simulation of their hand in the VR environment. I'd imagine that would probably activate the same mirror neurons that you might see like in like a mirror therapy session. So I think there's definitely like a lot of utility there. But again, I still think that the technology kind of has to catch up a little bit. I think in VR and AR, the concept of embodiment is critical, meaning that that virtual representation of that person or that limb inside that virtual environment, the patient has to really feel like it's them. And I think, if there's not a clear picture, there's like a lag in the technology, where there's like a lag between the actual movement and what appears in the virtual environment, that's going to negatively like affect the embodiment, even the skin tone. I mean, which is critical. That can affect the embodiment. So I think there's still work to do there, but I'm more excited about VR and AR from the aspect of visualization, which I think is definitely highly useful. Again, just motor imagery, a lot of potential there. And then also from a mental health perspective, I think there's like a lot of value there. But I think, like a lot of active movement where, the hand in the virtual environment is expected to move at the same, speed of the actual hand or whatnot. I think that it just concerns me a little bit. There's great companies out there. Neuro Rehab VR is one, XR Health. But I just think there's a little bit more work to be done in that area.
Cool. Yeah. I mean, I remember when I feel like all of the gaming consoles started releasing their own attempt at VR, and everyone was like, "It's here, we did it," and
Uh,
then it just
it
didn't.
isn't.
It wasn't
Yeah.
it. So it's interesting to
Yep.
hear that maybe there's some parallels
Yep.
there.
Haven't made it to the metaverse yet.
Yeah, right. Yeah. Okay, I'm going to move on to a couple of pre-submitted questions that we got from listeners out there. And this one I think is interesting because you mentioned that story earlier about your PT friend whose name I've already forgotten, and I apologize, but you gave him a great shout out. So that's got to
I
be worth
did.
more
I
than
did.
me remembering it. This question is from Yolanda Ortiz, and it is, what are you seeing in terms of evidence that supports OT using high intensity training as an intervention approach successfully in traditional rehab settings? And do you think OTs need to embrace the overlap of our PT friends if the evidence and outcomes are there?
Yeah, that's a really great question. From my knowledge, most of the hit research for stroke rehab is steeped in, functional mobility work or lower extremity work. Essentially, I haven't really seen as much for the upper extremity. I would imagine there's a utility there, but I think when we think about hit or like any high intensity workout, it's kind of steeped in like, kind of like cardio rehabilitation essentially. And again, I think about neuroplasticity, and one type of exercise that's effective for neuroplasticity is aerobic activity. And I know that hit, I would imagine that it would be useful for motor, relearning, again, tapping into that repetition matters and also intensity. Those are two principles of neuroplasticity. But I would imagine it's probably more of an anaerobic exercise, maybe with a little blend of aerobic. So I guess when thinking along those lines as far as facilitate neuroplasticity, I don't know. I wonder, would it be more effective than like more of a moderate intensity exercise? Where maybe you're moving at a steady pace, but maybe you're doing it for like a longer period of time and you're taxing that aerobic system more, which we know that's been shown to, you know, release good neurotransmitters and facilitate neuroplasticity. So that's kind of where I lean. I mean, I see the value in it, but I don't, to me, there's not like a lot of evidence right now specifically testing the upper extremity. But when you look at the theory of hit, I mean, it makes sense why it would work for the upper extremity. But I think anytime that we're doing like high intensity, workouts, especially if it's steeped in more of a cardio rehab kind of flavor, you have to be mindful of like safety, and you have to monitor that cardiovascular system. So, probably should be checking the heart rate of perceived exertion, maybe even, oxygen levels or blood pressure. And then also I think it's a delicate balance between doing lots and lots of reps and maintaining quality of movement. It's always if you do a lot, then the other one kind of sacrifice there. I just think that's important to be mindful of, because obviously you want to tax and challenge the system. But doing a whole lot of reps of a bad movement pattern, can have detrimental effects down the road. So I guess in closure, I'm definitely curious about it. I actually do think it has utility. I think we probably should be like our PT counterparts and explore it. The science behind it makes sense, but the evidence specifically for upper extremity rehab, at least in my knowledge, is more to be examined. So more work to be done. But I definitely would be curious in exploring that.
Cool. Sarah, anything to add on that front?
Oh, yeah, I have all kinds of
Too
thoughts.
many things to add?
Spitting about that. I think just generally, I was thinking about following the patient's interests. And as we have this cohort of people aging that enjoy high intensity workout, like if that's an interest that they had before the stroke, I can see like leaning towards that more for their stroke rehab as well. I think overall, I'm just so thankful to just always hearing Chris be like, keeping it simple still tends to be the best. For me, as someone in like rural Nebraska where I don't have access to like the greatest technologies or the greatest programs, like it feels edifying to be like, I can still deliver some of the best care, even without some of these fancier things.
All right. We're going to move on to our next question, just being cognizant of our time constraints here. This one is from Tracy Garrison. I am helping a patient walk through the vagus nerve stimulator process with Vivistim. How do you approach new procedures like this for individuals in the chronic stage of stroke recovery? This is actually interesting because we were talking a lot about vagus nerve before we went live, just like chatting in the green room with Chris, and both Vivistim and like various other vagus nerve discussions were had over the course of that like 20 minutes before any of you got here. So I'm excited for Chris to get to wax a little bit on this live.
Yeah, sure. Yeah, vagus nerve, or the vagus nerve, has always been interesting to me. Even before I knew of VV-stim, I was always, as a therapist, trying to engage the vagus nerve by, deep breathing, and because I always see an effect, like on a positive effect on spasticity or just movement when we focus on that deep breathing. But specifically to the VV-stim, I have evaluated patients for the VV-stim, but unfortunately, I haven't qualified for it yet. So I haven't been able to take a patient through the protocol. But again, the science, again, it makes sense. I mean, you stimulate the vagus nerve, facilitate release of positive neurotransmitters like acetylcholine and norepinephrine, which helps outward motor recovery. And then the fact that, you can elicit this, vagus nerve stimulator during like task specific training. I mean, again, the science makes sense. But as far as rolling that out to like a new client, I think, again, it's important to me. It's important to make sure that the patient has really engaged in a lot of other therapy approaches. And, maybe they've, experienced like a plateau, or they're just really at that point where they've done a lot, but they want to try something new. Because, I mean, this is a surgical implanted device. So, I mean, that requires a certain level of commitment. But yeah, I mean, if the patient has done a lot, they truly exhausted other options, and I really do think this is a valuable intervention to try to use. So yeah, I'm in agreement with it. I think it's useful.
And because again, like there's so many things out there that are available on all levels, right? On assessment level, on treatment level. On what advice do you have in terms of patient education when it comes to chronic stroke rehab?
Knowing what insurance covers.
Oh, wow. Yeah.
Finances matter. Yeah, and as a clinician, I'm always looking for, okay, what can I provide for my patient that I know will help out with their rehab trajectory, but insurance will cover. So that's always that's always like a very big question. And a lot of times I shape my recommendations around that. Or if insurance doesn't cover it, then just have a very frank conversation with the patient as far as what, they're willing to spend. And, I present options to them and I give them guidance, but allow them to make their best decision. But I think as clinicians, we have a duty to facilitate proper decision making for our patient. We don't tell them what to do, but we should support them in their decision making because there's a lot out there. And I've seen it, unfortunately, where, you know, companies have kind of convinced patients that, oh, this is the panacea, this is the device that's going to help you out. And it's like, no, we haven't considered how engaged your caregiver is. We haven't considered how good your core strength is, or your home setup, and can you even maintain or put on this device safely, or can you even do the required amount of therapy. So I just think it's critical to ask those questions and be strategic when providing options for patients or educating them on options.
And one of the handouts we worked with Chris on is those 10 principles of neuroplasticity, which you said this at the beginning, but those are just such a great, well, one, to help educate your patients on what those are. And two, those can just be a screening question for them as they're being confronted with all of these different options. They can kind of self check, like, is this going to help me meet these 10 at least one of these 10 principles of neuroplasticity in a way that I can't in my own low tech way, in a simple
Yes.
way. I also really like the Brunstrom handout that we created,
Yep.
Chris.
Yep. That definitely helps a lot. Yep.
Yeah, I was going to say we're going to talk about Brunstrom a little more here in a second because there's some questions from the chat that are revolve around that we're going to get to in our Q&A. As a matter of fact, we're just going to slide right into our Q&A. It feels like a good time. So I'm going to move on to some of the questions we've gotten from our live listeners to this webinar. I should say watchers. I don't know. I assume that people are putting it on and like doing other stuff. That's how I always do my like live stream events. Is I'm like chopping vegetables while it's happening. So that's what I assume. I assume everyone in our chat is halfway through an onion as they're listening to this. But I'm going to start with not a question, but a comment that I wanted to highlight from Leanne Quackenbush, which is my official favorite name for a person. I think that rules. Leanne Quackenbush says, thank you for mentioning skin tone as a key factor for visualizing self during engagement in VR. This is something many of us may not automatically think of, but need to be thinking of to address patients holistically. We'll move on to some actual questions now. Our first one is a clarification on mirror therapy. This one comes from Sandy Jackson. She asks, by mirror therapy, are you talking about using a mirror as biofeedback?
Yeah.
Great.
Yeah.
Easiest question. All right, moving on. Yeah, Q&A. I'm glad I saved so much time for the Q&A. So yes to that. Patricia Prats has a question as well. Patricia says, hi, I've been practicing for only 2 years as a COTA in Los Angeles, and I was wondering, with stage 5 complex combination movements under Brunstrom, how does one approach interventions when dominant UE is in hyperflexed and overpronated positions?
Ooh, good question.
Well,
I
from where
like
I'm
that.
sitting, it's really specific. I don't know.
It's a sharp OT right there for sure. So
Patricia, we got him.
Yeah, hyperflex and then pronated.
Yeah, dominant UE is in hyperflexed and overpronated position.
I mean, for me, pharmaceutical intervention, not just what's going on in the OT session, but Are you on a routine of Botox, at least every 3 months to control that flexor spasticity? Hopefully you are. A whole lot of preparatory activities. So, I feel like weight bearing can be ineffective. Also, utilizing either TENS, but then also a lot of functional electrical stimulation work on the extensor muscles to me is very effective. And then utilizing a lot of, would that be, manual therapy or even like deep pressure techniques to try to relax those overactive flexors. So just a lot of preparatory work. And then when engaging those more complex movements, I love to really focus on, if I have the appropriate equipment, like a gravity eliminated device. I don't know if you're familiar with the Sabo Moss, but essentially, you put your arm in this device and it removes the weight of the arm so it can move more effortlessly. So that's able to allow, opportunity to really be able to engage those extensions more and move out of that flexor synergy pattern. That's a pretty expensive device. So back to what we said earlier, what will insurance cover? They won't cover that, but they will cover the Sabo Reach, for example. So that's a dynamic orthosis that really facilitates elbow extension. So I would definitely use that, and I have used that for patients that are kind of at that stage. And then other than that, I mean, even a more low tech or no tech option is just basic. Well, trying to do it too much, but handling of that arm, actual just proper techniques to be able to facilitate that elbow extension. So just how we can do whether it be like a quick brush movement or tapping like of the elbow extensors, just to really kind of get that active, and then also at the same time be able to relax those hypertonic flexor muscles. Almost had me.
Ah, we'll get them next time.
Almost. Good try.
Uh, I've got a follow up just to piggyback on the Brunstrom aspect of the question. This one is from Tracy Garrison. I've seen the Brunstrom stages applied in various settings. While they do not appear to be strongly supported by evidence, what benefits do you find in using them? Also, how do you discuss gaining motor control rather than pure strength?
Yeah, I used to actually I used the Brunstrom. It just, well, at least for me, it helps me somewhat categorize where the patient is. I mean, if they're completely flaccid, if they have some movements within that flexor synergy pattern or within any synergy pattern, if they have movements out of that pattern, if they're really progressing to more of a normal movement. For me, it really does help uh, categorize. But aside from that, because if there's evidence that challenges it, again, just really relying on a spasticity measure. And what am I learning from like the modified Ashford? Because I find spasticity to me to be one of the more challenging barriers for active movement. And I think there's evidence that supports that the level of spasticity is a predictor of like motor recovery. So just really understanding where that patient is as far as their level of spasticity, kind of helps me quantify, their movement other than just basically using strength.
Cool. Tracy, I hope that answers your question. We have a few more before we wrap up our discussion with Christopher Gaskins on chronic stroke rehab. Our next question is from Jill Mott. Here's another short question. Jill Mott wants to know if you have any ideas for dual task treatments.
Dual task treatments, like, yeah, you might have to elaborate, like a cognitive task and like a motor task, like
Uh,
walking and doing like a cognitive task at the same time. I'm assuming that's what she's speaking to.
let's assume.
All right.
That's what I assumed.
Yeah. Okay. Typically for a higher, well, I do it typically for like a higher functioning patient where I actually am engaging in more either complex movements, or if I'm focusing on generalization of a task. So if I'm focusing on carryover, if I'm doing any kind of community reentry, so maybe we spent time working on I don't know, fixing your plate at home, but now you're going to go to a buffet with your family. So now I'm definitely going to not just challenge your motor function of you being able to use your hemiparetic hand to grab your plate as you put food on your plate, but I'm also going to distract you with conversation to see how that affects your ability to be able to
Mm.
stabilize that plate. Or now I'm going to distract you with sudden noises. Maybe somebody dropped a plate behind you or a glass broke. Is that going to now make you drop your plate? And if it does, that's going to cause social, embarrassment or concern. So definitely a huge fan of dual task training within that respect. But I typically utilize that more either for higher level patients or if I'm working on translation of that skill to like a community setting. A lot of good research behind dual task training, though.
I would love to actually. I want to end our Q&A on this question because I think it plays into the sort of social element that you were talking about just now, because I think this question is super important, and I'm glad we're going to get to touch on it here. This one's from Alana Woolley. Alana asks, Chris, what advice do you have for supporting and motivating patients as they cope with psychosocial stressors? And then lists as examples fear, frustration, role loss, etc.
Mm, yeah, that's a great question. The first thing I try to let them know is that it's okay to be affirmed in how they feel. Then I try to wrap community around them, where there's giving them accounts of patients that have been through similar things that they have, or with the patient's consent. If I can use a cheerleader that I might have on my caseload that has been through a similar scenario, try to connect them. But then also making sure they just have the proper resources. Have you spoken to a psychologist or a therapist? Make sure they're okay to feel empowered to have that space to do that. If I have to help facilitate that appointment, because yeah, you definitely want to make sure that they're getting the best care. And as an OT, we definitely trained in from a psychosocial perspective, but I believe in bringing in experts when necessary. So definitely try to facilitate getting connected with a therapist if needed. I would say those are the main things, and then also just showing them that they can do things that they thought they could not do, and v- videos are a key thing in my practice. So we take videos throughout the plan of care. So if think about it, y'all. I mean, it can be hard for patients to really understand how far they've come. Because I mean, I know I could do a better job, but when we create therapeutic goals, I don't think I reflect with the patient enough on those goals to show them when they're accomplishing goals and moving on. They don't have a clear visual representation, but if I show them a video, them trying to grab a cup a couple months ago versus now, that hits a lot and that can improve their mood. And then lastly, yeah, just letting them know that I mean, a lot of times with stroke rehab, I mean, it is just a long journey, sometimes a lifetime journey. I don't know if we're often honest enough with our patients in saying that. But I think the quicker we can made them realize that this does not represent who you are. You are a stroke survivor, but you're also an amazing cook, a great poet, a loving mother, whatever it may be. I think I can just help them along their trajectory.
Yeah. Oh, I love this as a place to end our discussion. It's especially this idea of like, because the treatment and the work is often on a curve, and because you're in it all the time. And I guess this goes for pretty much anything you're working at, but especially as a patient in this sense, when you're on that curve, the moment to moment, you don't feel the big changes, but being able to visually see on a video, like, here's a point in time and here's a point in time, and being able to compare that is so huge.
Yeah.
So thank you so much, Christopher Gaskins, for joining us, Sarah Lyon for being here
Mhm.
for this discussion on chronic stroke rehab. Thank you so much for joining us.
Definitely a pleasure.
If anyone has lingering questions, I know we didn't get to all of them. the clinical decision support pages do have comments, so drop those in there and we'll keep updating these pages and adding to them based on your comments. So it's so powerful for me to hear Chris speaking and to see these members that we know with these questions, and I definitely want to get to them. So ask them in the club and we'll get to them on these pages.
Yeah, please do. These discussions and the learning is always ongoing, even if our discussion right here, right now, is coming to a close. But thank you for joining us, all of you in the chat and all of you listening through your various podcast appropriation channels, wherever you're getting your stuff from. We will catch you on the next episode of the OT Potential podcast. Thank you so much. Take care.
Thank you.
Thank you.
Thank you for joining us on the OT Potential podcast. To earn 1 hour of AOTA approved continuing education for your time today, you will need to sign in or sign up at otpotential.com. Once you're in the OT Potential Club, you will find a 5-question post-course quiz connected to this episode. When you pass the quiz with a score of 75% or higher, you will be able to download a PDF certificate that certifies your completion of this course. Okay, I want to thank you for joining us today, and we'll see you next time.